Thanks everyone for listening. And I always thought if we have to discuss what is the sequence, unless I have a case in front of me, I cannot imagine what patient what I have to give. So let us. I will present a case, and then we can have a discussion
Sure,
on
no
that.
problem. Good
We
idea.
can think what we can have. So just to introduce, prostate cancer is very common cancer. The incidence is lower when compared to the West, but our mortality is higher. So the problem is we are not doing PSA screening. That therefore the incidence is less, but we are not picking up early stage. Therefore, the incidence to mortality, the ratio is almost the mortality is higher when compared to the West. And this is the incidence of prostate cancer worldwide. It is not that we have less prostate cancer cases. It is not. We are not doing a routine PSA screen. That's the reason why we have a less incidence of prostate cancer, because we are not doing test to pick it up. So we pick it up. We don't have a routine PSA screening. That's the reason why we are not picking those early stage prostate cancers. We are only picking only locally advanced or
Do you think
metastatic.
is a good thing or bad thing?
So it has both the answers, sir. Good is you don't overtreat patients. The patients may die without even
Yes,
having
yes.
symptoms.
I guess the SEER data, if you look at from America, the incidence has gone up, the detection is gone up, but death rate is remained same. So that means we are picking up more diseases, but they are innocuous. They are not killing a people. But now, so far, what we have, we may not be able to pick up who is actually a virulent disease, where we require treatment. Though we have some treatment, good armamentarium.
It is something
Yeah,
like
please go
COVID,
ahead.
something like COVID only, sir.
Yeah.
So, so these are the risk factors. What are the reasons why we get? There are some unmodifiable, modifiable risk factors. Unmodifiable are race, ethnicity. So it is said that Africans or black people have more prostate cancer. If you have a family history, you are at fourfold increased risk. If you have a germline BRCA or a HNPCC, you are again at a higher risk. And modifiable are if I am obese, if I have a diet, whatever we blame with a non-vegetarian diet, a red meat, all are blamed. And smoking is a definite risk factor. And in the right, you can see those fancy mutations being there, and which I will be dealing with that near future. So we all know what the prostate cancer is all about. This is all prostate cancer we have. So we have only 10% patients coming with de novo metastatic disease, because prostate is there right in the urinary outflow tract. They have obstruction as a predominant problem. The LUT is what we call, and they have bone spread and they come with bone pain. So we pick up majority of localized disease. This is a Western data we have. But only less than 10% come with advanced disease. So this is good in a way that in lung cancer, we pick up, or in a prostate cancer we pick up only in advanced disease, whereas here we have in ovarian cancer we pick up advanced disease. So whereas here in prostate, because they have an early symptomatic manifestation of lower urinary tract obstruction, we're able to pick up majority of them in an early stage disease or a non-metastatic disease. So we have M0, and then you did radical prostatectomy or you did radical RT, and then there is a biochemical progression. And then we have something called non-metastatic CRPC, where enzalutamide, apalutamide have good evidence where we can give. And then we have metastatic recurrence, and then everybody going into CRPC. So the moment it is metastatic CRPC, the survival is 1 year, 2 years, 3 years. So this is what we have, depending on the biology of disease. So maximum 2 to 2.5 years is what the lifespan. Once it is metastatic CRPC, median survival. So metastatic CRPC is a difficult disease to treat. So we have to do much before the patient lands up with a metastatic CRPC, because the moment it is mCRPC, we all know nothing much can be done. It's all about titrating drugs and waiting for the patient to succumb. So this is the genomic landscape. I thought it is interesting, and I would present. So majority of cancers where there are mutations which are there in the early stage. For example, if you have a breast cancer, the mutation that is there in the early stage and the mutation in the advanced stage are not different. They are truncated mutations. If a ERPR HER2 positive breast cancer is there in the early stage, it remains so even when it is metastatic. Rarely it changes, around 20% patients. Similarly in lung cancer, but that is not a case with prostate cancer. If I have a non-metastatic prostate cancer, the tumor burden, the number of mutations it has, is far less than a metastatic CRPC. That is, when the more terminal you go, the more of proliferation it happens in the later on, there are multiple mutant pathways that come in. So these AKT-mTOR pathway, the androgen receptor mutation pathway, the DNA repair pathway, and so many. So if you want, if you do a genetic test in the first prostate biopsy sample which you did, or a radical prospective specimen which you did years before, you will not be able to pick up the classical mutations which are there in CRPC. So it is always better you will do a rebiopsy at the time of a CRPC, because the number of mutations change between a localized CRPC and metastatic CRPC. So more to add is, those tumors which have multiple mutations are the ones which have a bad biology, are the ones which are going to have metastasis. Whereas those which do not have much mutations tend to be more localized and they don't metastasize. So it is both the ways it is correct. So metastatic have high mutations, and having high number of mutations make them metastatic. So that's a bad biology disease. So just to say the fact that there is a heterogeneity in the type and the number of mutations which you have in a localized versus metastatic CRPC. So if at all, if I'm looking for a next generation sequencing to look for what all the mutation targets I have to have a tissue from a metastatic CRPC than a tissue from the prostate, which I did on the day one when I detected prostate cancer. So similar thing again depicted here. You can see those triangles. The first triangle in the right, you can see the metastatic prostate cancer has a large number of mutations. What are they? TP53 mutation, RB1 gene mutation, P10 mutation, BRCA2, CDK1, MYC. So what is the point if I sent the sample for NGS and I got all these fancy mutation? What will I do with this? I really don't know, unless I pick up something like BRCA2 where I will be able to handle, or if I have a HRR mutation, I can do something. But if I have a TP53, I have a RB1, I say it's a bad mutation and I can't do anything. So just to say that whatever I pick may not be targetable, but in a metastatic setting, these mutations are there in higher number than that in the localized. So in localized prostate cancer, it is unlikely you find a P53. It is unlikely you find a P10 or a BRCA or a RB or a MYC mutation. So we all know that we have come much beyond docetaxel, abiraterone, and enzalutamide. Now we are speaking of pembrolizumab, we are speaking of olaparib, and we have CDK4 inhibitors are coming in, and so on, and alpelisib. So they all are making their way inside until we have trials to prove them. So prostate cancer again is something like lung cancer, where it is now becoming a molecular driven mechanism and pick up the mutation and treat the target and get benefit. So what is known as a personalized cancer treatment in prostate cancer. This is an advanced setting. This is not in a localized setting. So in a localized prostate cancer, there is no point sending for next generation sequencing or doing all these mutations. So you can do it only when you have a strong family history where you want to pick up similar mutations in the family members. But for that particular patient, to screen for second malignancies, you can do, but not for treating that prostate cancer as such. So these are the prevalence of altered genes in prostate cancer. We have BRCA1, BRCA2, ATM, CDK, MMR, P10, and AKT-mTOR. So these are the pathways which we have, and these are the proportion of mutations which we see in a prostate cancer. Very important, what we need to look into is the HRR. The BRCA1, BRCA2, ATM are important, and then the MMR is important, because we have drugs, we have immunotherapy drugs, and we have olaparib, and I will tell you platinum also works well in this set of patients. So what we understood till now is that the mutational biology is different in an early versus an advanced disease. We must do an NGS if at all we're doing in a CRPC setting, advanced setting. You need to get a new tissue than an old tissue. So now let me go to a case. So this is a real world case presented in a ESMO, and I'm just reproducing that for better understanding. So here we have a 59-year-old gentleman. In June 2017, he was diagnosed with a primary bone metastatic prostate adenocarcinoma. He had undergone a biopsy, and it was Gleason's 4+4, 8, and then he had a PSA of 72.4, and it was a T2B N0 M1B disease. And you can see the number of bone lesions were 5, and there was also a femoral lesion. So very important, whenever I look into a metastatic prostate cancer, I want to understand, of course, Gleason's is important, PSA is important, but I want to classify that into a low volume disease and a high volume disease, or a low burden disease or a high disease burden, because it not only gives me prognosis, it also helps me to decide what treatment I'm supposed to give. So, for example, we have these latitude and charted trials. These are the two randomized trials that have defined what is the volume of disease. If it is, they are more, then it is considered in latitude, it is high disease burden or high volume disease. Whereas if it is 4 or more plus one non-axial metastasis, if you have, then it is a high disease burden. So whatever the definition is, we must understand disease burden helps me not only to prognosticate, but also to choose what treatment I'm supposed to use. So for that, if I have a low disease burden, let us say less than 4 meds, then I will give definitive radiotherapy. I mean, I will give a good dose of radiation to the prostate also. So, and number one, number two, if it is a low disease burden, then the benefit of docetaxel in the HSPC setting is not that significant. So, with these are the two conclusions what I can get looking into the disease burden. So, not only prognostic but also predictive. So, it predicts should I give local RT to prostate or not. If it is low disease burden, I must give, because it improves overall survival. And if it is low disease burden, then docetaxel has not improved overall survival. So I will be using abiraterone or enzalutamide in the hormone sensitive setting. So this is a hormone sensitive setting. This is a new patient where it is a castrate sensitive prostate cancer still I'm speaking about. And then the comorbidities were hypertension, and very important, remember this patient had his mother who had breast cancer at 40 years of age, giving in good insight into this patient had a strong family history. So family history of breast cancer, and this patient has developed prostate cancer at a relatively young age, that is 59 years. So family history of breast cancer increases the risk of prostate cancer in males. Okay. So what is the primary treatment this patient received? So the moment I see a metastatic castrate sensitive or a hormone sensitive prostate cancer, the treatment is androgen deprivation therapy. We can have a lot of argument whether it is a agonist or a GnRH antagonist or a GnRH agonist, or we have oral tablet right now that has come up, that is the most potential GnRH antagonist. So that, but you have to have, the most important treatment is androgen deprivation therapy. The moment a patient has metastatic prostate cancer, the patient should have testosterone levels less than 20, preferably, or less than 50 throughout his lifetime. There's no question of him having testosterone above 50. So he must have a profound androgen suppression throughout the moment it is metastatic prostate cancer. So whatever mechanism I use, I have to have a suppressed testosterone level. That is one. Secondly, only ADT versus ADT plus systemic therapy, we have enough evidence to say that ADT plus systemic therapy improves overall survival. So in the present era, if I have a metastatic prostate cancer and I say you just take leuprolide and you go home, you're feeling fine, and then the patient comes back quite soon, within a year or within 6 months to 1 year with a PSA progression. So this hormone sensitive span, or the time to subsequent treatment is shorter, and also the overall survival is shorter if I am not giving systemic therapy along with androgen deprivation therapy in a metastatic hormone sensitive prostate cancer. So just a LHRH agonist, just leuprolide or a digaralex is not sufficient. We must give androgen deprivation therapy with systemic therapy. So what systemic therapy? If it is a low volume disease, then enzalutamide and also abiraterone, preferably. The preferred option is abiraterone is preferred. If it is a high volume disease, then docetaxel is preferred. So this patient had a high volume disease. If the patient can tolerate well, not that I am not saying that if high volume abiraterone won't work, but if you look into the performance status, high Gleason score, high disease burden, then you have both the options, dosi and abiraterone. Depending on the flexibility, you can use both. So there has been network meta-analysis comparing these. It is one is saying that abiraterone works better in visceral mets. Another one is saying that docetaxel works better. So there is controversial data as to which is better. But high disease burden, docetaxel is a good option because when the patient progresses and becomes CRPC, his performance status will not be that good to tolerate chemotherapy. Therefore, give stronger treatment before his general condition deteriorates. That is one. And number two, it's also the choice of the patient. You want to take a tablet until go on taking tablet until progression, or you want to get rid of this by giving 6 cycles of docetaxel and going for observation. So the comorbidities, general condition, patient choice, all these become important when I choose docetaxel and abiraterone in a high disease burden. So this patient was started on LHRH agonist, and the patient received docetaxel in the hormone sensitive prostate cancer. You can see the duration June 2017, and then the patient was given from August 2017, August to October. So up to October, he went on to receive docetaxel. In November, the patient developed progressive disease. So you can just see after completing 5 cycles of docetaxel, he could not take the 5th dose. Then the patient was randomized to Archie's trial. Leave apart the Archie's trial, he was randomized to placebo arm, so he did not receive any therapy. So this patient basically received LHRH agonist therapy, and then he should have received 6 cycles of 3 weekly docetaxel. But after 5 cycles, whatever toxicity or because of COVID situation, in that time it wasn't there. So whatever reason, the patient did not receive 6 cycles. So the last what he received was in 2017 October. So and then so this was the thing. Then the patient became, in a matter of 3 to 4 months, the patient's PSA started raising. So you can see the chart. So he received LHRH agonist and then 5 cycles of docetaxel. In a matter of 3 months, the patient developed PSA progression. So you can see the graph over here. So the starting PSA was 72. After LHRH agonist and docetaxel, it came down to 1.4. And then when we followed him up, when he was in observation, in a matter of 3 months, the PSA again increased to 5.6. So after completing docetaxel, just within a matter of 3 months, this patient developed disease progression. So his total duration of androgen deprivation therapy was also not more than 1 year. So it was less than 1 year of androgen deprivation therapy, and this is something like not an androgen sensitive disease as well. So then the patient was started on abiraterone plus prednisolone initially for 1 year, for 12 months, and then he developed radiological progression, PSA progression, and then enzalutamide, and then he went on to receive carboplatin plus cabazitaxel, and then Taxol plus ifosfamide. So you can see the sequence of treatments this patient has received. And also the patient received in Jan 2019 palliative RT2 hip. So just you can look into the sequence of treatments what we have given. We must give ADT plus docetaxel, high disease burden. And when this patient progressed, after a very short progression-free interval on docetaxel, was it right to give abiraterone for this patient? This is first question, because if a patient has got a good disease control for at least over 1 year of androgen deprivation therapy, that is the patient which is sensitive to androgen deprivation, and he is sensitive to endocrine therapies. Whereas when you have a very short progression-free interval on androgen deprivation, was it wise to give abiraterone first? And then why not enzalutamide? Because in CRPC, we have data for enzalutamide also. So was giving abiraterone better or was giving enzalutamide better? And then there has been cabazitaxel, which is given later on in the 4th line. Should I have used cabazitaxel before abiraterone? So, and then what was this carboplatin given? Was it really required? And what is this Taxol and ifosfamide? So let us go into each aspect as to why they have chosen and what better we could have done for this particular patient. So again, looking into the PSA, so you have a y-axis, the PSA, and the x-axis is the time. So the patient was metastatic hormone sensitive prostate cancer, a large disease burden. Initially received LHRH agonist plus docetaxel 5 cycles, and then patient was on placebo. That was an observation. And then the patient initially, so just with 3 months of PSA progression and radiological progression free interval, the patient progressed. After progress, and the duration of control of metastatic HSPC was less than 1 year. So knowing that the patient was on abiraterone, even then the patient went on for a year, and then on enzalutamide again for 1 year, and then you can see the PSA values once it is on enzalutamide, the PSA never dipped. So carboplatin was given, and then taxol-ifos. You can see that there was no response to chemotherapy at all. When you use it for the 4th or the 5th line, then no matter what you give, the response is very poor. So we have, I will show you the data of the CARD trial. So what the CARD trial says, the CARD trial says is, if a patient is progressing on ADT less than 1 year, then that is not a candidate for anti-androgen therapy. We should have given cabazitaxel for this patient instead of abiraterone. With this, we could have had a longer progression-free interval. That is one we could have had. And secondly, should I have used abiraterone first or enzalutamide first? Again, we have some indirect evidence saying that if I have to sequence two novel anti-androgens, it is better to use abiraterone first, followed by enzalutamide. So the sequence of abi followed by enzalutamide is apt. And then what about platinum? So this patient was BRCA2 mutant, and therefore platinum is also a right option. Whereas whether you should combine with taxane, again there is no trial addressing it. But looking into the rapidity of progression, they have done it, but the tolerance is an issue. And taxol-ifos, because they suspected neuroendocrine transformation, and they did what this blue line signifies NAC, the neuron specific enolase, and that is not indicated to be done. But when you are suspecting a neuroendocrine transformation, especially when the patient is on oral anti-androgens for a long time, you see the PSA not rising much, but there is radiological progression, then you think of a neuroendocrine transformation, and doing NSC is not the standard of care. So the patient then underwent biopsy. So you can see that the patient has exhausted almost all treatment options. We know that prostate cancer patients live in spite of all these treatments, and still they ask what next to be done. So then he again underwent a prostatic biopsy to look into the molecular markers. You can see that it's the Gleason's 4+4 is now Gleason's 4+5. That signifies a more aggressive transformation, and a strong PSMA staining in spite of being castrate resistant, and a strong AR expression. So the patient, as expected, turned out to have a deleterious BRCA2 mutation present, and the allele frequency was 70%. And rest all other mutations which is being there, we don't know what to do with these mutations. So then what next was there? So we have olaparib being there after having a BRCA mutation being there, and the results are excellent with olaparib in a BRCA mutation. So one more thing, what we need to note is germline mutation. So germline mutation is doing BRCA from peripheral blood. It can be done in ovarian cancer and breast cancer, but not in prostate cancer, because you will be missing more than 50% patients who they may not have a germline mutation, but they have only somatic mutation. Therefore, you must do these testing on a newly biopsied CRPC prostate cancer, not on the blood. So germline BRCA is not the way to go. So this patient received olaparib, but this patient had already progressed on platinum, and as expected, the PSA went on rising and did not respond at all. So what are the points we can discuss in this patient? So this patient had a disease burden, high disease burden, whether giving docetaxel was correct or whether giving abiraterone was correct in the frontline setting. So would I have made any difference if I would have given abiraterone first Or if I knew that if the BRCA2 was there, mutant from the front line, if I would have added platinum in the front line, should have been controlled. These are the points which I can discuss. Then the disease burden is latitude and charted. They have given some definitions, and whether should I have used cabazitaxel as per the CARD trial, or should I have used abiraterone, what has been used here, and when do I suspect neuroendocrine transformation, and when to test for HRR aberrations, and these are the somatic and germline. What should I do? Germline mutation, and what are the resistance mechanisms to PARP inhibitors? So this is one important slide. What I can say is the x-axis is the number of bone mets and the y-axis is the hazard ratio. So you can see that if the number of bone mets is less than 4, you have an excellent hazard ratio of around 0.75 and the upper confidence interval less than 1. So you can have an approximate number of less than 4 bone mets. Then we must give radical RT, prostate directed RT, which improves survival. So the take home message is, if you have a low disease burden in those patients, we must subject them to prostate directed radiotherapy along with ADT, along with systemic therapy. This is as per the Stampede trial. And this is another one where could we have placed radium for this patient because it was bone confined disease? Yes, there is an overall survival advantage, but radium plus abiraterone, it has not shown any benefit. So this patient was young. Should I have done BRCA mutation in the frontline setting and not to wait, or should I do a germline mutation? Again, this is to be contemplated. And this is the data we have for metastatic HSPC, ADT plus docetaxel. I think with a high disease burden, giving ADT plus docetaxel was justified because this has improved overall survival. And then for CRPC, what combination should I have used? Cabazitaxel first and then abiraterone docetaxel? I think probably yes, because of the CARD trial, which I will show. So these are some conclusions of the sequencing. So what they say is whether I use cabazitaxel first or last, cabazitaxel has its efficacy in whatever lines it uses. It is one of the most strongest taxane, and it overcomes docetaxel resistance. That is one. And this is the CARD study design, which I was saying. This is patients with metastatic CRPC who progressed less than 1 year on androgen deprivation therapy. So in those patients, the randomization was cabazitaxel versus novel androgen therapy. And what the study clearly said was the progression-free survival was significantly better if I use cabazitaxel than abiraterone enzalutamide. So for this patient where I saw the period of ADT or the period of castrate sensitivity was less than 1 year, probably choosing cabazitaxel was a better option in an index case, which I showed. So this is one important take-home message what we can take. If the patient has progressed on less than 1 year of androgen deprivation therapy, this patient is a candidate for chemotherapy and not for further androgen inhibition. And this is one more phase 2 crossover trial. What the study has said is, if I sequence abiraterone followed by enzalutamide versus enzalutamide followed by abiraterone, what they say is the responses are better if I use abiraterone first followed by enzalutamide. So A comes first. So as we have the alphabets, A comes first and then comes E. So abiraterone first followed by enzalutamide, very soft retrospective data. This is some take home message which we can have. So before I conclude, I would say a few things. Number one, when I have a metastatic prostate cancer, I must always classify it into whether it is a low disease burden or a high disease burden. If it's a low disease burden, then docetaxel is not a great option. Abiraterone preferred, and then enzalutamide. If there's a low disease burden, along with ADT, along with abiraterone or enzalutamide, we must give prostate directed radiotherapy. This improves overall survival. Up to 4 or 5 metastases we can include. And number two, if we have the duration of androgen deprivation less than 1 year in a hormone sensitive period on ADT, then this patient should go for chemotherapy and not for androgen deprivation as per the CARD trial, where those patients who have received ADT and in those patients who have received docetaxel, if the hormone sensitive duration is less than 1 year, cabazitaxel did better than novel and anti-androgens. And if I'm using the sequence of abiraterone and enzalutamide, using abiraterone first and then followed by enzalutamide has better PSA responses. We don't know the survival data, but the A followed by E is the way to go. So with this, I would conclude, and I would thank everyone for their patient listening. Thank you.